So the next topic is breast cancer screening guidelines. Canadian Task Force 2018 on the breast cancer recommendation for women aged 50 to 74, recommending screening with a mammogram every 2 to 3 years. The decision to undergo screening is conditional on the relative value that a woman places on the best possible benefit and harms with from screening. For women ages 40 to 49, recommending not screening with a mammogram, the decision to undergo screening is conditional on the relative value with a woman places a possible benefit and harms from the screening. Recommended not screening clinical breast examination to screen for the breast cancer. Conditional recommendations not evidence. Recommend on breast women. Recommend not advising women to practice breast self exam to screen for the breast cancer. Recommend not using MRI, magnetic resonance imaging, tomosynthesis, or the ultrasound to screen for the breast cancer in the woman not at higher risk. For some information on benign breast cancer and breast cancer and the breast lesion. Lung cancer screening guidelines 2016 Canadian Task Force on the Preventive Healthcare Recommendation for adults ages 55 to 74 with more than 30 pack years smoking history who currently smoke or quit smoking less than 15 years ago. Recommend annual screening with low dose CT scan up to 3 consecutive times. Screening should only be carried on out in a healthcare settings with the expertise in early diagnosis and treatment of lung cancer. For all other adults, regardless of the age, smoking history, or other risk factors, recommend not screening for the lung cancer with low dose CT scan. Recommend that the chest X-ray not to be used to screen for the lung cancer with or without sputum cytology. Then comes the colorectal cancer screening guidelines. 2016 Canadian Task Force on the Preventive Healthcare Recommendations recommend screening adult age 60 to 74 for CRC colorectal cancer with the FOBT or the FIT test every 2 years or flexible sigmoidoscopy every 10 years. Recommend screening adults ages 50 to 59 for the colorectal cancer with FOBT, either FOBT or FIT every 2 years or the flexible sigmoidoscopy every 10 years. Recommend not screening adults ages more than 75 for the colorectal cancer. Recommend not using colonoscopy as an screening test for the colorectal cancer. Then comes the screening for all the people who have already high risk. So man and woman which is symptomatic, then go for the diagnostic workup. If the man and woman which is asymptomatic regardless of the age but positive family history, then comes HNPCC, hereditary non-polyposis colorectal cancer or familial adenomatous polyposis, genetic counseling and specific screening. Then comes HNPCC, hereditary non-polyposis colorectal cancer. We will do colonoscopy every 1 to 2 years. Begin at the age 20 or 10 years younger than the earliest case in the family, whichever comes first. Familial adenomatous polyposis sigmoidoscopy annually begin at age 10 to 12. Then comes AAPC, attenuated adenomatous polyposis. Then we do colonoscopy annually begin at the age 16 to 18. Then it comes the one first degree relative with the cancer or adenomatous polyposis at the age less than 60 or two or more first degree relatives with a polyp or the colon cancer at any age. Colonoscopy every 5 years begin at the age 40 or 10 years younger than the earliest case of the polyp or cancer in the family, whichever comes first. Then comes the one first degree relative with the cancer or adenomatous polyp affected at the age more than 60 or two or more second degree relatives with the polyps or the colon cancer. Average risk screening and then begin at the age is 40. One second degree relative or the third degree relative affected. Then we do average risk screening and which begins at 50. Polyps found at colonoscopy. 1 to 2 adenomas less than 1 centimeter. We do colonoscopy in every 5 years. More than 2 adenomas, colonoscopy in every 3 years. Incomplete examination, numerous polyps, advanced adenomas, and malignancy or the large sessile adenomas, colonoscopy after a short interval based on the clinical judgment. Then comes the cervical cancer screening guidelines for women. 2013 Canadian Task for the Preventive Care Guidelines recommendation for women aged 30 to 69, recommended peptidoglycan smear, which is basically pap smear, or lipid based cytology LBC for cervical cancer every 3 years. For women age 25 to 29, recommend pap smear or lipid based cytology for cervical cancer every 3 years. For women age more than 70 who have not been adequately screened, recommend continuous screening until 3 negative tests who has been obtained. For women more than 70 who has been adequately screened, for example 3 consecutive negative pap tests in the last 10 years, recommend that the routine screening may cease. For other information or the cervical cancer, that is basically provincial or the territorial guidelines for the Ontario guidelines. Then comes the table, which is basically the normal. Then we will do routine screening in every 3 years. Inadequate sampling, then we repeat cytology in every 3 months. Adequate sample, no T-zone. So basically routine screening in every 3 months. Then comes the ASCUS. If ASCUS is shown up like atypical granular cells of unknown origin, then it depends on the age. If the woman is less than 30 and there is no HPV DNA testing available, then we do cytology in 6 months, which comes out negative, or ASCUS is more than ASCUS is present. Then we do colposcopy. If it's negative, then repeat cytology in 6 months. Then it comes negative, then routine screening, and ASCUS is present, then we do colposcopy. Then the woman more than 30, HPV DNA testing, negative, then positive. If it's negative, then repeat cytology in 12 months, and then positive, then we do colposcopy. Then it comes the atypical abnormal squamous cells cannot rule out HSIL, then we do colposcopy. Then comes the AGUS, which is basically atypical granular cells of unknown origin, so and atypical endocervical cells or atypical endometrial cells. Then we do colposcopy for plus minus endometrial sampling. Then we do LSIL, which is low grade squamous intraepithelial lesion. Then we do colposcopy, either colposcopy or we can repeat cytology in 6 months. That is basically done is negative, or ASCUS is more than if ASCUS is present, then we do colposcopy. If it comes out negative, then we do the cytology in 6 months, and if it comes out negative, then we do routine screening, which is every 3 months. If it's come out as positive or ASCUS is present, then we do colposcopy. HSIL, then we do colposcopy. Squamous carcinoma or other significant changes, then we do colposcopy. Then comes the prostate cancer screening. For men age 55 to 69, recommend not screening for the prostate cancer with a PSA test, which is basically weak recommendation, moderate quality evidence. Clinicians should discuss the benefits and the risk of screening and its potential consequences with each man in the context of its preferences. For the man age less than 55, recommend not screening for the prostate cancer with a PSA test. For the woman, as for the man age more than 70, recommend not screening for the prostate cancer with a PSA test. Basis of recommendation: the potential small benefit from the PSA screening is outweighed by the potential significant harm of the screening and associated follow-up treatment. For men ages less than 55 or more than 70, there is no evidence that the screening with the PSA test reduces mortality, whereas there is evidence of harms. For the man age 55 to 69, there is inconsistent evidence of the small potential benefit of screening and evidence of harms. So that's about the screening. Then comes health promotion and counseling.